Hi, everyone. My name is Jessie Palazzolo, and I'm going to be discussing the U.S. response to the Ebola epidemic of 2014. We're going to look at the emergency preparedness, ICS, and the public health implications of a deadly virus. Ebola virus is actually one of, there's four, also abbreviated as EVD, and it's a type of hemorrhagic fever. They were first discovered in 1976 in parts of Central Africa. It's a zoonotic disease where African fruit bats are likely the reservoir. It is spread then person to person through bodily fluids. The incubation period is 2 to 21 days, except the average is 8 to 10 days. And fun fact, it can only be spread when you are symptomatic. So unlike COVID, where people could spread it prior to symptoms presenting, this spreads only when you have the symptoms. The event started in 2014 in the countries of Liberia, Sierra Leone, and Guinea within the continent of Africa. It had a global impact as it made its way to the United States in September of 2014. This is the largest Ebola outbreak in history. There was 28,000 suspected, probable, and confirmed cases. There was 11,000 deaths, over 11,000 deaths. And then the first case was identified here in Texas, which we'll dive into later, in September 30th of 2014. The lead federal agency in this epidemic is the United States Agency for International Development, which operates through the Office of the U.S. Foreign Disasters Assistance, OFDA. And kind of a fun fact, and I included here, is that a U.S. ambassador of the affected country declares a disaster to USAID. And then that is where a DART team is deployed, and they coordinate and implement a field response using a response management team. Other agencies involved is going to be the Department of State, and there's a long list that I don't need to read to you. But in this case, we'll talk about the CDC and then private sector and some local communities and governments later in the presentation. U.S. hospitals, in terms of the Ebola response, you can see that list too. It's Emory University in Atlanta, University of Nebraska Medical Center, National Institute of Health Medical Center, and NYC Health Bellevue Hospital. And we will focus mainly on the Texas Health Presbyterian Hospital within this crisis, but specifically. The ICS and HCIS domestic response timeline, as you can see, a Liberian national returns from Africa, is evaluated at Texas Health Presbyterian, given antibiotics, sent home. I'm pretty sure they weren't expecting to see Ebola, but he returns on September 30th, and that's when the CDC confirms Ebola, and the patient is admitted into the hospital. October 1st, Texas governor leads a meeting with the response team, and then subsequently on October 2nd, people are being identified as having contact with the patient, EOC is activated, and as well as PHOC, which is the public health system being activated. Continued on the domestic response timeline, between October 2nd and October 6th, that's when the Texas Task Force is put together on infectious disease preparedness and response. We get the SMOC, which is the State Medical Operations Center, on board, and State Operations Center activated and deployed. And that is a part of the Command Assistant Team, member to the City of Dallas Emergency Operations Center, which we're all familiar now with the term EOC. October 8th, patient succumbs to Ebola. And then October 9th, a public education campaign is rolled out by the Dallas County EOC. October 11th through the 14th, then we have 2 nurses that test positive for Ebola, and the State Medical Operations Center is reactivated. So that kind of gives you an idea of what it looked like upon having the sick patient report with symptoms, upon his death, and the processes that took place, and anyone that also contracted Ebola from treating that patient. This is the response assessment that I found through my research. Is there was a slow initial international and domestic response. So the slow response wasn't just something here within the United States. It was really on an international level. And that was the feedback throughout many documents that I looked over. It was a top-down information flow, CDC, Department of State Health Services, then down to city websites, face-to-face in schools within those communities that were affected by Ebola. The respondent assessment was what stood out to me was inadequacies of SOPs that were identified. Political and administrative tensions were an issue, and risk communication failures. So on the one hand, there was inadequacies of SOPs, but it was also noted as a strength that standard operating procedures in the Texas Ebola crisis, 66.7% of the respondents agreed that the use of SOPs are helpful to create the following things like trust, professionalism, clarity, helped with the issues of confusion, and it really did overall provide a basis of where to start. Flexibility is necessary in this process, but at least having that guideline, that framework that the SOP provides is helpful. Okay, so Ebola response in terms of ESF number 8 within the public health and medical sector. These are the capabilities that I felt most suited this situation, which I'm not going to read them verbatim, but health surveillance, medical surge, patient care, assessment of public health and medical needs, all hazards, public health and medical consultation, technical assistance, and support. These are areas within the U.S. Ebola response that fit in describing how these ESF capabilities were used. The U.S. Ebola response in terms of evaluation of preparedness plans. One of the research studies I looked at 4 community participant groups, and they all had direct involvement in the U.S. Ebola response within New York City, Texas, Nebraska, and Atlanta. And they wanted to, from the feedback they wanted in the research, they wanted to develop a resilience checklist. And so they looked at healthcare, local, state, and federal public health personnel, law, local and state emergency management personnel, academia, local and national media. And from these interviews, they were able to put together and create a resilience checklist. And that a chain of command via the ICS was critically important. As well as strong coordination and communication between healthcare, local, and state. In fact, I can't, my face is covering that. Oh no. Let's go back. Oh, it won't let me go back. Okay. Changes in emergency plans in public health system. What did we learn from this? And there was a lot of information out there. And the changes that needed to be made started with funding. So the fiscal year 2015 emergency Ebola appropriation came about with Congress finalizing the appropriation of funds And as you can see how it's laid out in terms of domestic response and money for research and development activities, but with the caveat that some of this funding could also go to international settings as well. Long-term support, the Kaiser Family Foundation, who were a part of this report, identifies the need to transition to a broader support for health systems and public health capacities internationally and domestically. A continuation of changes in the emergency plans and public health system is with the Texas Ebola crisis specifically. They created and amended existing SOPs. They created new protocols for PPE, sharing of information with first responder agencies that expanded, and there's more clarity and just better risk communication overall. Modifying ambulance for infectious disease patients. I mean, something that is so highly contagious and highly deadly, like Ebola. These ambulances were not equipped to handle these very ill patients. Regular drills and test plans, I would think is like the basis of emergency planning and execution. Texas Framework on Information Sharing was modified, and then there was also a House Bill 2646 in Texas that amended the Texas State Health and Safety Code. U.S. Ebola response in regards to public health impact. So you had mentioned that a new public health emergency policy framework would be very important. And they identified 14 policy planning and learning directives to help share a public health emergency framework. And they did develop that, and I have a link on here, and you can see it from 2023. Andrew et al., his research really identified a need for further research in areas of leadership, perceived success response, and an understanding of the characterization and measurement of effective emergency response, and that specifically had to do with the state of Texas response. And then Bell et al., they looked at how the CDC came together and developed an Ebola response team, and to really help hospitals develop preparedness for this high-level infectious disease. They wanted to strengthen all hospitals nationwide in their preparedness. From that, 2 tiers of hospital readiness and frontline health care facilities came about, and that is through the Ebola assessment hospitals. And I don't like that I'm like covering this up. It's taking away my mojo here. Trying to find the other one. Oh, heavens, heavens, heavens. Oh, sorry about that. 2 tiers of hospital readiness and frontline healthcare facilities, Ebola assessment hospitals, and Ebola treatment centers. By July 2015, a total of 55 hospitals in 17 states were designated by state health departments as Ebola treatment centers. So headway was definitely made. I think from what I gathered in all the research I did, that there were a lot of flaws, a lot of weaknesses in the system. The strengths being SOPs, and so amending those and creating more where necessary was very helpful, especially in the state of Texas, and that the CDC, looking at this from a national standpoint and helping equip hospitals, and then also getting the funding, billions of dollars of funding to address Ebola and how we can be, it's really bright, stronger as a nation to deal with the highly infectious diseases that come to us internationally or start here domestically. Thank you for listening.